Hi, I'm Dr. Jack Cush, Executive Editor of RheumNow.com. It's the 22nd of April, Friday, and it's the RheumNow Week in Review. This week from the social media feed, a few interesting articles. There was an interesting report from the GI world that perioperative use of methotrexate did not increase post-op complications, sepsis, or infections related to IBD patients undergoing surgery. Speaks to the issue of perioperative use of methotrexate and whether it's a detriment to patients. Looks like not from this report. A systematic review by David Felsen and colleagues has also looked at the use of methotrexate and shown that across the board in all the randomized clinical trials, methotrexate was probably underdosed, underscoring the point made by Jim Odell at the national meeting last year. The highest dose that was used in clinical trials was 20 milligrams. The highest dose of parenteral use, which was sparingly low, was only 15 milligrams, suggesting that we probably could do better in our use of methotrexate. I made a tweet this week, said that there's a desperate need for new therapies for inflammatory and erosive OA. OA itself is often not paid attention to in the research world. Certainly this devastating complication or subset of patients, and it's a large subset, who need new advanced therapies. DMARDs, biologics don't work in patients with erosive OA. There is a trial underway right now with IL-1 inhibitors. It remains to be seen whether that'll work. Interestingly, GSK announced the start of a new phase 2 trial testing its use of a monoclonal antibody against GM-CSF in patients with inflammatory OA. Promising, but we need to see results. And lastly, the issue of biosimilar stays in the news. There was an announcement from the CEO of Celltrion that pricing of Inflectra, the Remicade or infliximab biosimilar that will probably hit the market in 2017, is likely to be only 20 to 30% less than the marketed price of Remicade. So if you have big expectations, you may want to cut those back a little bit. There are a few interesting blogs this week, some really, really important blogs. One from David Bezetsky from Duke. David wrote a very interesting article about how we use pictorial representations of disease in our teachings, and maybe when we get it right and maybe when we don't. It's a really nice read, and you should look at that on the blog section of RheumNow.com. Another blog came from Kevin Winthrop, who blogged about the do's and don'ts of vaccinating our patients, and he's written this specifically for rheumatologists. It's a quick read. It's highly instructive. Kevin and colleagues also recently published their findings in a report that looked at the use of guidelines and implementation of guidelines in how RA patients receive their vaccinations. The bottom line is that while a majority of patients receive influenza and it goes up with age, so roughly around 80%, there's 20% who don't receive influenza, and it's a much more dismal number for the pneumococcal vaccinations. Read that, and then read Kevin's blog about when you should and should not use those vaccines and how to use them appropriately. There's an interesting report from PNAS about defensins, specifically alpha defensins and their role in inflammation, where they've been shown to both curtail the infection potential of certain microbes, and at the same time limit the amount of pro-inflammatory cytokines that may be elaborated in the response to inflammation and or infection. The point being that this understanding could lead to newer and novel therapies to control both antimicrobial, or have an antimicrobial and anti-inflammatory approach to numerous diseases. There was a review of the 10-year results of the BEST trial that was reported in Annals of Internal Medicine that you should look at. You probably know those results. It talks about the numbers of patients who are able to achieve long-term remission and drug-free remission. And while the most aggressive therapies, the COBRA-like regimen Group 3, the biologic infliximab methotrexate regimen in Group 4 achieved the fastest response, the bottom line was after 2 years and out to 10 years, all four groups, monotherapy, switch therapy, all achieved the same outcomes. Why? Because they were all treated in a treat-to-target fashion. Very instructive. They also, another report that appeared a few months ago, looked at the role of flares, and that patients who have flares in the BEST cohort were the ones who also had the most damage and worse outcomes. probably should pay more attention to flares and have better protocols for managing flares. Throwing steroids at all problems is probably not a good idea. And lastly, there's an interesting report about from the osteoporosis meetings internationally that looked at the rate of refracture after someone's had a first fracture. It turns out it's much higher in the first few months, but even the rates of refracture are still increased as long as 10 years later. So anyway, that's the news from this week in RheumNow. For the citations and links to these featured items, please go to RheumNow.com and you can find them for your further reading. You can look under the video tab to also find some of the citations and their links on the website. Be sure to follow the wonderful, exciting world of rheumatology on RheumNow.com, where if you register, you can receive daily, weekly, or tailored emails or topic reports to your liking. That's it for now. Tune in next week.